So, good afternoon, everyone. So, today we'll be discussing a very important topic, the initial management of respiratory distress in neonates. Okay. So, greetings from the land of Lord Jagannath. So, coming to the developmental stages of lung. So, as you know, from 0 to 40 weeks, that is the normal gestational age. So the lung goes through 5 stages. First is the embryonic stage, that is from 0 to 6 weeks. Then pseudogandular phase, that is from 7 to 16 weeks. Canalicular stage, 17 to 24 weeks. And the alveolar stage, that is more than 34 or 36 weeks of gestation. And there is a structural changes of the lung during this period. And the surfactant also starts forming from 20 weeks onwards from the canalicular stage, and it matures around 34 to 35 weeks of gestation. Similarly, the lung fluid, initially the lung fluid is being secreted and that helps the lungs to grow. It is helping the lung to grow. Then once the process of labor starts, then there is a steroid response that helps the absorption of the lung fluid. The channels which are actually secreting the lung fluid in the initial phases, now they actually go into absorptive phase and they start absorbing the lung fluid. So what happens when there is a process of labor, the lung fluid gets absorbed, and once the baby is delivered, so there is less amount of lung fluid, there is a decrease in pulmonary pressures. Once the baby starts breathing, there is a decrease in pulmonary pressures and the breathing is established and the respiratory pattern is established. So this is the normal basic physiology that we need to understand before actually we go how we assess and manage a baby with respiratory distress. So what we'll be discussing today is what is the cause of respiratory distress, how we define the respiratory distress, how we can assess and how we'll manage the respiratory distress in the neonatal ICUs or the SNCUs. So defining the respiratory distress, actually different groups are defined differently. So what is more important is WHO has defined respiratory distress is respiratory rate more than 60 or less than 30 breaths per minute with grunting, chest indrawing or central cyanosis. That is, there is features of increased work of breathing. Similarly, ICD-10 in 2016, they have defined it as a condition of the newborn that is marked by dyspnea, cyanosis with predominant signs of dilatation of the lallar naji, expiratory ground, retractions. Similarly, another respiratory distress support group in the neonate working group, they have defined that respiratory distress is abnormal respiratory rate along with clinical symptoms that is consistent with labored breathing. And the abnormal respiratory rate may be a tachypnea, that is respiration rate more than 60 per minute, or it may be a bradypnea, that is respiratory rate less than 30, or it may be apnea, that is cessation of respiratory efforts for at least 20 seconds, or if it is less than 20 seconds, if it is associated with bradycardia or desaturation. And the clinical symptoms that are correlated with labored breathing are nasal flaring, noisy respirations, retractions, grunting, or central cyanosis. The NNPD, that is the neonatal perinatal database, they have made it very simple. They have told any two of the following three, that is present, then we can tell it as a respiratory distress. That is tachypnea, respiration rate more than 60, retractions or recession, intercostal or subcostal recessions, grunting. But before actually monitoring the respiration rate, we need to ensure the baby is calm and quiet and the baby's temperature is normal. And second, the baby has to be in a neutral position or a sniffing position. The neck should not be too much flexed or too much extended. If it is too much flexed, you know, in a newborn, the trachea is cartilaginous and it is very soft. So if you flex the neck, so there will be obstruction of the neck and there will be high respiration rate. Again, if the neck is too much extended, the tongue also falls back and again that obstructs your trachea and there will be increase in respiration rate. And always respiration rate, you count for minimum 1 minute. So never count for 10 seconds and multiply by 6. So always you count for 1 minute. So these are the three things we need to ensure before actually we monitor for the respiratory distress. Then there are three terminologies what we should to know. One is respiratory distress, second is respiratory failure, and third is respiratory arrest. So we should target to intervene a baby at or recognize a baby at the phase of respiratory distress so that we can avoid or we can avoid the respiratory failure or baby going into respiratory arrest. So respiratory distress, what we have discussed, so high respiration rate along with increase in work of breathing. But when you tell it is a respiratory failure, when there is a ineffective ventilation or oxygenation or both, and it is usually associated with oceanic sensorium and slow or fast breathing. But respiratory arrest is, so there is no spontaneous breathing and it is associated with cyanosis and unresponsiveness. So as I told, so our target is to intervene at the stage of respiratory distress and not allowing the baby to go into respiratory failure, where intubation is the only choice. So first thing is knowing the severity of respiratory distress. So coming to the severity, the first thing what I have described is the when you tell it the baby is in a respiratory failure, if the baby is there is a altered sensorium, the baby is drowsy, then that is a danger sign, and that we can tell the baby is in respiratory failure. So we need to look for the vitals, look for the cyanosis, breathing pattern, work of breathing, retractions or grunting, look for any stridor, look for the oxygen saturation, and look for a systemic examination, that is the respiratory system examination. So always we need to quantify the amount of respiratory distress. Simply telling the baby's work of breathing is high, or the baby has a retraction, or the baby has a grunting may not solve the problem. Rather, we need to go for the respiratory distress assessment score and quantify the amount so that when we are giving some respiratory support, then actually we can see the progression, whether the baby is improving or the baby is deteriorating, looking at the number, the respiratory distress score number. So we have got three scores. One is the Downey score that typically we use for the babies who are tall. The Silverman-Anderson score that we use for the premature babies or babies who are less than 36 weeks. And there is another WHO score. But mostly in the NICUs, we use the Downey score or the Silverman-Anderson score more commonly. So coming to the Silverman-Anderson score, actually, so it is predominantly used for premature babies, and the SS score is a better indicator of the functional respiral capacity of or the alveolar opening. So high SS score tells us that the alveoli are more collapsed or there is low functional respiral capacity in the alveoli, and it correlates well with the mortality. So if you look at the SS score, it is divided into three scores actually. There are 5 points what we need to observe, and the score is 0, 1, and 2. So first is the upper chest, second lower chest, third Gifford retraction, fourth is the nasal flaring, and fifth is the expiratory grunting. In the upper chest, so how they have classified the upper chest, just look. So you take a from the mid-axillary line. From the mid-axillary line, what is above is the upper chest. From the mid-axillary line, what is below, that is the lower chest. So what you see, so initially the score is 0, means both the in the upper chest, abdomen and the chest wall, if both are growing, means moving synchronously, then we tell it is a score of 0. But if the chest is going up, but the abdomen is not going synchronously, then we tell it is a, if there is a lag on inspiration, then we tell it as a score of 1. And if there is a seesaw movement, then we tell the score is 2. So 1 is synchronized, score of 0, lag on inspiration, that is score of 1, and seesaw movement, that is score of 2. This is the scoring for upper chest. For the lower chest, that is below the mid-axillary line in the posteriorly, if the retraction is absent, then we tell there is a no retraction. But if the retraction is visible in the lower part of the intercostal space, then we tell it is a score of 1. But if it is towards the axilla, towards the apex of axilla, then we tell it as a marked retraction and we put it as a score of 2. Then similarly, Gifford retraction, if there is no retraction, then we give it a score of 0. Just visible, we score it on 1, and if it is a marked, then we score it as a 2. Similarly, for the nasal dilatation or nasal flaring, we have score of 0. If there is no flaring, minimal, that is 1, and if it is marked, then is 2. Then fifth point is the grunting. So grunting is just a expiratory sound. If there is no grunting, we tell it is score of 0. And if you are able to hear the grunting only with the stethoscope, putting over the axilla, then we put it as a score of 1. But if you are able to hear the grunting by the bare ear, then we have to score it as a 0. But when you want to hear for the grunting, go to the level of the baby and hear. So that will be, you cannot stand and just hear. So then you put it as a score of 2. So that is very important. And believe me, the expiratory grunting is a ominous sign or a dangerous sign. So expiratory grunting means the baby is trying desperately to open up the alveoli by premature closure of the glottis. So this is the typical sound the baby makes. So you can feel the baby is actually making this sound by closing the glottis so that some amount of expired air is remain in the alveoli and allowing the alveoli to open. So this is about the SA score, and we classify if it is 0 to 3, then it is mild. If it is 4 to 6, it is moderate. And if it is more than 6, then we tell it as a 6. Then another score, that is the Downey Vidyasagar score. So this is Vidyasagar sir is an Indian person. So again, it is used for the term babies. Here we have got 5 points: respiratory rate, air entry, retractions, grunting, and cyanosis. If the rate is less than 60, we tell it is 0. If it is from 60 to 80, we score it as 1. If it is more than 80 or the baby has apnea, then we score it at 2. If the air entry is normal and equal bilateral chest walls, then we put it as 0. If the air entry is diminished, we put it as 1. If there is a silent chest or there barely audible air entry, we put it at 2, score of 2. Similarly, for the retractions, if no retraction, score of 0. Mild retraction, score of 1. Severe retraction, score of 2. For grunting, it is similar to the SS score, no grunting, score of 0. If it is audible with stethoscope, score of 1. And if it is audible with bare ear, it is score of 2. Similarly, cyanosis, so that is the, if the cyanosis is visible, in room air, we put it as a score of 1. And if it is visible with, even with 40% oxygen, we score it at 2. So again, the mild severity is score of 0 to 3, moderate is from 4 to 6, and severe when the Downey score is more than 6. And it has got very good correlation with the blood gas. So just remember, for the term baby, we have to go for a Downey score. For premature baby, for Silverman-Anderson score, and these are better indicators, or this can quantify the amount of respiratory distress that the baby has. So again, this is another classification, WHO classification of respiratory distress, and you can see in the slide how we can classify mild, moderate, and severe. But mostly because we are using Downey and SS score, so I'm not coming in details about the WHO's classification. But again, what is more important to us is to know the danger signs in a neonate with respiratory distress. So any baby where the sensorium, there is an altered sensorium, baby is lethargic, baby has hypotonia, poor feeding, then definitely it is a danger sign. If the baby is having apnea or gasping efforts, or there is a irregular breathing efforts, then also it is a danger sign. Similarly, increased work of breathing, particularly when the baby has a severe nasal flaring, the baby has a grunting, or there is a paradoxical movement of the chest wall or the seesaw respiration, then we can tell this is a danger sign. Similarly, silent chest or poor air entry bilaterally, that is a danger sign. Central cyanosis or saturation less than 90%, even with oxygen. If the baby has a bradycardia, baby has gone into shock with poor perfusion, hypotension, it is a bad sign. Or when you are going in ABG and you are seeing in the ABG there is a worsening pH or severe rise of PCO2, then we tell it more than 60, then we tell it is a danger signs in respiratory distress. So just coming to the etiology we can classify depending upon the gestational age and the time of onset of respiratory distress in the babies. So in premature babies, the common causes, if the respiratory distress has started from the delivery room or within the first 6 hours of life, the classical causes are, one is the respiratory distress syndrome or the hyaline membrane disease, where actually there is a surfactant deficiency because of the premature babies. Second, it may be congenital pneumonia because of risk factor for sepsis. Third, it may be because of lung malformation, transient tachypnea, or a pneumothorax that has happened because of the resuscitation of premature baby at the time of delivery. Then within 6 to 24 hours, it may be congenital pneumonia. aspiration syndromes, PDA, shock, congenital heart disease, lung malformation or pneumothorax. And if it is persisting, the onset is after 24 hours, then it may be acquired pneumonia, PDA, shock, aspirations, hemorrhages. Likewise, in a torn baby, if the onset is within 6 hours, the common three causes are, it may be because of perinatal asphyxia, meconium aspiration syndrome, or a TTNB, or rarely it may be because of malformation, pneumothorax. Even RDS may be present in a torn baby, particularly when there is a infant of diabetic mother. Similarly, within 6 to 24 hours, it may be because of aspiration, congenital pneumonia. More than 24 hours, again, acquired pneumonia, shock, congenital heart diseases may be the common causes. So again, we need to look for I'll give you a brief overview, what are the risk factors, and depending on the risk factor, how we can know or how we can predict the causes. So if the baby is worsening respiratory distress on bag and mask ventilation, then the cause may be a congenital diaphragmatic hernia or a Ehrlich syndrome. If there is a history of prolonged labor, difficult labor, assisted delivery, fetal distress, meconium stent liquor, then the cause may be a asphyxia or perinatal asphyxia, asphyxiated lung injury, meconium aspiration syndrome. If there is elective cesarean section and no significant perinatal risk factor, it may be transient tachypnea of newborn. If there is background history of maternal fever, foul smelling liquor, prolonged rupture of membrane, it may be we are dealing with a case of congenital pneumonia. If the mother has not received antenatal steroids, premature delivery, incomplete dose of antenatal steroids, diabetic mother, still we can think it is a respiratory distress syndrome or a hyaline membrane disease. If there is polyhydramnios in the antenatal USG, we can suspect there is some upper airway malformation like tracheoesophageal fistula, congenital diaphragmatic hernia. If there is a oligohydramnios, then we can think the mother has a pulmonary, the baby may have a pulmonary hypoplasia. Similarly, maternal hypertension, preeclampsia, we can think of asphyxia as a cause. If the mother has a significant antenatal blood loss from placenta previa or abruptio, we can think shock may be the primary cause of respiratory distress. Similarly, if the worsening of respiratory distress after feed, we can think there may be a GERD or there may be isolated cleft palata. If the crying worsens the cyanosis, then we can think it's a congenital heart disease, but crying relieves the cyanosis, there may be bilateral coronal atresia. And if there is, the cause is, it's a chronic course and the baby is persistently CPAP dependent or HFNC dependent or oxygen dependent, we can think bronchopulmonary dysplasia or a chronic lung disease may be the cause, or there may be atypical infection, viral infection, particularly CMV infection, or a recurrent aspiration from GER, which is very common in the extremely low birth weight babies, or a osteopenia of prematurity because of the poor mineralization of the chest walls. Then coming to the physical assessment, so we have to look for sensorium, color, tone, posture, response to touch, cry, gestation, weight of the baby, look at the vital parameters that I have described, look at the work of breathing, look at the perfusion, look at all the danger signs. Then coming to the systemic evaluation, just look at if the baby is SGA, it may be meconium aspiration syndrome, asphyxia, polycythemia may be the cause. If it is a large birth dead baby, then again polycythemia, RDS, congenital heart disease may be the cause. If there is portophasis, then hypoplastic lung may be the cause. If there is a barrel chest test or the increase in anterior posterior diameter of the chest wall, then we can think meconium aspiration may be the cause. And if the baby is having excessive frothing from the mouth, then we can think tracheoesophageal fistula may be the cause. Similarly, if the baby has scaphoid abdomen, distal heart sounds shifting to the right side, then you think maybe possibly we are dealing with a case of congenital diaphragmatic hernia. So next, identifying the lung physiology. So how you know if the baby has a isolated tachypnea or tachypnea associated with grunting, stridor, retraction. So if it is an isolated tachypnea, so maybe the cause is not related to the lung pathology. It may be because of congenital heart diseases, or it may be because of metabolic causes like hypoglycemia, hypothermia, acidosis from renal failure, anemia. If the baby is having grunting, indirectly it tells me that the alveoli are collapsed, and alveolar lung diseases like RDS, pneumonia may be the cause. If there is a stridor, that tells me the upper airway obstruction, and central cyanosis may also tell me I am dealing with a case of congenital heart disease or it's a very severe lung disease. But again, I need to come here. What are the possible clues to the congenital heart diseases? So when the cyanosis is disproportionate to the clinical status, or there is a differential cyanosis from the upper difference in saturation between upper limb and lower limb, single heart sounds, there is a presence of murmur, hepatomegaly, sudden clinical deterioration, no response to oxygen, or cardiomegaly in the X-rays, we can have a doubt that it is a congenital heart disease. Again, we can differentiate whether the cause is from the respiratory cause or the CVS cause. So if retraction is present, then mostly I am dealing with a respiratory cause where the cardiac evaluation may be normal. Second heart sound may be sleep because of the pulmonary hypertension. We can see parenchymal lesions in the X-ray, PCO2 may be high, and there is a hyperoxia test. So in the hyperoxia test, then if the PO2 is more than 300, that rules out cardiac disease. But with the advent of echocardiography, bedside echocardiography now, we are less dealing with hyperoxia test now. So coming to next step is the investigation. So the basic investigation, what we need to do is go for the PCB to rule out polycythemia, look for RBS to rule out if whether there is a hypoglycemia or not, then sepsis screen to rule out if the baby is having a congenital pneumonia or a early onset sepsis. Blood culture, if you are planning to start antibiotic and we are thinking of sepsis, then we have to go for a blood culture. X-ray chest or the long ultrasound. In present era, we used to go for to look for what may be the possible lung pathology if is there or not. Then blood gas to know the severity of the respiratory distress, whether the oxygenation and ventilation is happening correctly or not, that we can go for a blood gas. So 2D echocardiography, when you are thinking that baby may be having a congenital heart diseases, then or if there is a persistent respiratory distress, unexplained previous deaths in the baby, then we go for a 2D echocardiography to rule out the possible causes of congenital heart diseases. So next, the radiological signs. So again, so the lung may be a normal volume lung, a low volume lung, or a high lung volume. So the typical lung in the X-ray, the normal lung, so it should be anteriorly we can see 6 rib spaces and posteriorly up to 8 rib spaces. That is the normal lung volume. So low lung volume, if it is lesser, we tell it is a low lung volume, and the typical classical example is the respiratory distress syndrome or pulmonary hyperplasia. The high lung volume, typical description is the meconium aspiration syndrome or even the transient tachypnea of newborn or hyperventilation. Also, we can see pleural effusion, lobar consolidation, reticulogranular pattern in the X-ray, and we can get a diagnosis. So in the left-hand picture, you can see that is the normal X-ray. You can look at the heart shadow and the lung films. The lung films are looking normal with normal vascular pattern. But in the second picture, you can see that this is the normal lung picture, but you can see there is a fluid in the fissure. So, and there may be some amount of effusion if you look at in the right costophrenic angle. So we have a normal lung field, we have a slightly echogenic lung fields with fissure in the lung with pleural effusion. Then the diagnosis may be a transient tachypnea of newborn, but again, transient tachypnea of newborn is a diagnosis for exclusion. In the RDS, so what you see a low volume lung, and you can see the reticulogranular pattern in both the lung fields. Similarly, meconium aspiration syndrome. So what you see a hyperinflated lung fields. Then again, patchy opacity over by the bilateral lung fields you can see. CDH, you can see congenital diaphragmatic hernia. You can see the bioel loops that is filled inside the lung, and this is the cardiac border that has been pushed to the right side. In the last, in the right hand corner, you can see the pulmonary hemorrhage. Just see the reticulogranular pattern diffusely over both the lung fields. You can have an idea of the pulmonary hemorrhage. So what is the evidence of hyperinflation? I have already told. The normal lung is within 6 ribs anteriorly and 8 ribs posteriorly. But if the lung expansion is more than 6 ribs anteriorly you are seeing, or more than 8 ribs posteriorly you are seeing, then you tell it is a hyperinflation, and there is a flattening of diaphragms, increased lucency of the lungs, or air under the heart or herniation of the lung to other side, and ribs look more horizontal. So these are all the features of hyperinflation. So because of the increased radiation or we are avoiding long X-ray chest in the NICU nowadays after after the availability of long focus. So we have got definite features, but from the nursing point of view, I'm not going in details about the long ultrasound and what are the pictures, but just remember. So this is just a normal long. What you see, this is the ribs, and this is the plural lines, and normally it will be A lines. But if there is more fluids, so it will be all looking hazy. So it will be compact B lines. So and this is a subpleural consolidation with multiple opacity, patchy opacities. So I'm not going into details. So this is the X-ray, how the X-ray looks like in RDS, and this is the picture what it looks like in a long ultrasound. Okay. So this is again in a transient tachypnea of newborn. So this is beyond our scope. I'm not going in details. But what is more important for us to know the monitoring of oxygenation and ventilation, how we do. So our target for every baby, whether it is a term or preterm, the target saturation should be 90 to 94%. The PO2 we can monitor by a transcutaneous PO2 monitoring, or we have to go a blood gas, and from the blood gas we can monitor the PO2, that is the partial pressure of oxygen in the arterial blood, and the PCO2, that is partial pressure of carbon dioxide in the arterial blood. And we can calculate the oxygen index, oxygen saturation index. But in current time, actually we are not doing so frequently blood gas. We rather want to monitor the baby clinically and observe the baby. Blood gas we do only when there is a clinical deterioration, clinical worsening, or the baby is in shock. Then we actually go for a blood gas studies. So once we decided to start any ventilator support for a baby with a respiratory distress, then the best ventilator should be the ventilator that causes least lung injury to the baby. That is our target. So as we discussed earlier, so our target is to detect the baby in a stage of respiratory distress, assess the danger signs of respiratory distress when we tell the baby has gone into failure, quantify the amount of respiratory distress, then put the baby on some respiratory support, and the support should provide least lung injury. So what are the targets of our support? The target of our support is the baby should be comfortable. That means the work of breathing has come down and there is an adequate lung recruitment, and it has optimized the oxygenation and ventilation, correct the VQ mismatch, and also avoiding lung hyperinflation and lung injury. So this is the target. So how you know the support what we are providing to these newborn babies is actually adequate or not? So when the baby's respiratory support is adequate, the baby who was more irritable will be much more comfortable. It is not fighting with the respiratory support. Then the work of breathing is coming down, or the SS score, Silverman Anderson score, Diane score is coming down, retraction has coming down, the grunting has is gradually normal, and there is a normal capillary repeat time, perfusion is normal, the saturation is maintaining in the 90 to 94%. In case you are doing a blood gas, the blood gas has to be normal. That is, PO2 should be between 60 to 80, PCO2 40 to 60, and pH of 7.35 to 7.45. So this is our target, and how you know the respiratory support is adequate. So once we decide we have to put the baby on a support, then we need to decide which support we need to choose, whether we need to choose for a non-invasive support or we need to choose for the invasive support. I just give a brief overview here, just some moment here regarding choosing the respiratory support. So in non-invasive, we have got 4 options: CPAP, non-invasive ventilation, or heated, humidified high flow nasal cannula, or a nasal high frequency oscillatory ventilation. In invasive, we have got 2 options: invasive mechanical ventilation or synchronized invasive mechanical ventilation, or high frequency oscillatory ventilation. These are the 2 options. But basically, how you decide if the baby is in respiratory failure, the baby doesn't have a respiratory drive, then either we may have to, our plan is to control the full respiration of the baby. So there we have to intubate this baby with the proper size endotracheal tube and connect the baby to a mechanical ventilation. So those aspects, what is the rate, PIP, PEEP, FiO2 and respiration rate, what will set that is we are not discussing today. That will be discussed in the basic aspect of neonatal ventilation when we taught. But remember, when we are putting the baby on invasive ventilation, so the four things what we are going to set is PIP, that is the positive inspiratory pressure, PEEP, that is positive end expiratory pressure, FiO2, that is for the titrated, what is the saturation and what is the respiration rate. So how you decide what is the PIP? So basically PIP, that is positive inspiratory pressure, will look at the chest rise. So the PIP, what we set is the minimal PIP, that is giving me a adequate chest rise. It is not too much increasing. Similarly, how you decide PEEP? The looking at the retractions. So PEEP is actually correlates with the alveolar volume, what I described about the functional respiral capacity. So you give the PEEP such that the work of breathing or retractions are minimal and the FiO2 is minimal. FiO2 we set depending upon the target saturation, that is 90 to 94. So practically any baby who is on respiratory failure, we are deciding to put the baby on invasive ventilation. So for the babies who are on respiratory distress, when we decide which baby will decide on CPAP, NIV or triple HFNC. So CPAP is the best choice actually in most of the units we started. So HHFNC actually it is not used as a primary respiratory support for babies less than 28 weeker baby or even less than 30 weeker baby. But we can utilize for a baby post extubation if the baby is with a have a good respiratory drive. Just post extubation we can utilize, but not a primary support for a baby who is less than 28 weekers or even less than 30 weekers. So NIV, which group of babies? So NIV will use where we want to have some control of the respiration. Like if the baby is breathing, but the breathing efforts not that good, and we don't want to intubate the baby because of the complication of or to avoid the complications of invasive ventilation, then we can put the baby on NIV. In NIV, again the same things what we are setting in the invasive ventilation, we set the same thing. We set the PIP, we set the PEEP, we set the rate, we set the FiO2. So NIV is nothing but invasive ventilation without a ET tube in situ. Simply we can tell in that manner. But avoid NIV in the babies who are in shock or the baby has a poor perfusion. Then the last, the CPAP, which is actually the best choice in the NICU nowadays in a baby with respiratory distress. So what are the things you need to set? So three things we need to set in a CPAP. One is the flow, second is the FiO2, and third is the CPAP pressure. So the rule of 5 previously we used to follow, that is 5 flow, pressure of 5 and FiO2 of 50%. But now the decision how much we need to start depends upon the retraction. You can start with 5, look at the retraction, then you titrate. The retraction should be minimal, and so you can titrate 5 to 6 to 7 to 8 depending upon the retraction. Similarly, FiO2 you can titrate depending upon your targeted saturation, that is from 90 to 94%. But what is more important is when you start a CPAP, so the baby has to be breathing spontaneously. So that is the criteria. So CPAP cannot be given in a breathing baby who is not breathing. So CPAP or NIV for a baby who is on spontaneously breathing. So this is the primary what we decide and how we decide to start on respiratory support. Oxygen therapy, so some persons don't include under the respiratory support. So oxygen therapy or the low flow oxygen therapy, what we tell now. So when we are giving a flow from 0 to 1 liter per minute through the nasal cannula, and what we tell high flow nasal cannula or triple HFNC, what I described earlier, when the flow is more than 2 liter per minute and we can go up to 8 liter per minute. So when we are giving oxygen, again, we have to give the oxygen that is 0 to 1 liter per minute, but our target saturation should be 90 to 94%, and we should both avoid hypoxia and hyperoxia. Okay, but the anytime we are using more than 2 liter, we have to heat it and humidify it. So we have to give it a heated and humidified, because when we are giving flow at more than 2 liter per minute, it actually bypasses, because of the high flow, the normal humidification mechanism of the upper airway, the sinuses, the nasal piphyses. So The nasopharynx, it has got normal humidification mechanism. So when we are giving at a very high flow rate, more than 2 liters per minute, actually it is bypassing the normal humidification mechanism of the body. So that's why we need to heat and humidify. One, if you are not heating, if you are giving a cold air, and the cold air will induce bronchospasm. If you are not humidifying the air, then what will happen? The secretions, there will be drying of secretions, more crusting inside the alveoli, in the chest wall. So the because of the more secretions, it will damage, and more heat, it can damage the dry air, damage the vibrissae, the microvilli in the alveolar wall, and that can again lead to more risk of infection. So anytime we are giving a high flow, it has to be heated and humidified. So again, supportive measures is very important when we are planning for the management. Thermal care, nursing, IV fluids, nutrition, antibiotics, caffeine, inotrope for perfusion, we will be discussing. So antibiotics, which group of babies we need to give antibiotic? Respiratory distress or tachypnea is maybe a sign of antibiotic, but it is not everything. So we need to decide which group of babies we have to start antibiotics and which group of babies we need to start caffeine. So lastly, I'll just summarize in two case scenarios about what we have discussed in last half an hour. So just first case scenario, just look at this case scenario. I'll just give step by step how the baby was delivered, how it has come to NICU, how you handle the baby in the NICU initially, how will you monitor this baby in the next 48 to 70 hours, and what may be the possible diagnosis and outcome. So in the first case, we have a torn baby. So this mother is a 28-year mother, primary mother, married since last 4 years, admitted to the labor room at 38 weeks of gestation for safe confinement. Mother had gestational diabetes and was on diet control. So she had a antenatal USG done at 32 weeks that has shown gestational age of 34 weeks with weight of 2800 gram. AFI was 20, Doppler study was normal, and there was no gross fetal anomaly. So elective LUCS was planned as this is a common scenario. The mother doesn't want to take the pen. So elective LUCS was planned. The baby has cried after birth, did not require any resuscitation. But what has happened? The baby developed respiratory distress in the delivery room. And the birth weight was 3400 grams, and it was a boy baby. And what was the indication of admission to the NICU here? The baby was shifted to NICU in view of breathing difficulty. So once you have received the baby in the NICU, we note the timing of receiving in the NICU. The first thing is always putting the baby in the radioentourage, that is temperature stabilization. So we used to follow a TABCDEF, a simpler formula for the initial stabilization. T for temperature, baby was received in the radioentourage. The admission temperature was 36.3 degrees centigrade, which you know that is cold stress, more practical because baby has been transferred. So you know here from the temperature point of view, the admission temperature, if it falls less than 1 degree centigrade below normal, it increases the mortality of newborn by almost 30%. So we need to be extremely careful to maintain the temperature at admission. So always we have to transfer the baby from the labor room to the NICU, ideally in a transport incubator. If it is not available, so now the warming device like embrace is available, where you can wrap the baby in a embrace and shift the baby so that the baby remains warm, or even we can shift the baby with covering the baby with a warm cloth. So our target is maintaining the temperature in the normal is at the time of admission, but here it is 36.3. So the airway, for the airway management, what the nursing officer has done, put the baby head in a neutral position, that is neither it is too extended, neither too much placed. She has put a shoulder roll, and there was some secretion, so clear the secretion. Then for the breathing, what she has done, she has connected the baby to a pulse oximeter, and the respiration rate she counted, it was 76 per minute. Saturation was showing 86%, and the Silverman-Anderson score was 5 by 10. So with this background, with Silverman-Anderson score 5 by 10, baby not maintaining saturation, high respiration rate, so they decided to put the baby on CPAP. So the initial CPAP pressure, what we decided to put it at 5 and 30%. Then she evaluated about the circulation and found out the heart rate is normal, 160, pulses are well felt, capillary fill time is less than 3 seconds, baby looks pink, periphery are warm. So the perfusion is normal. Next C is the consciousness. So baby is alert, active. So she was not much worried. Then what are the D for drugs? So what drugs will be given now? So injection vitamin K, because it's a torn baby. So we have given vitamin K 1 milligram to the IM to this baby. We have not decided to give any antibiotics because there is no risk factors for this baby. E for electrolytes. So because the baby was just delivered and brought to the NICU, so electrolytes are not needed for this baby at present. For sodium, potassium we used to give after 48 hours, and only thing what we give within 24 hours is calcium. So here, unless the baby has signs of calcium, the baby has low calcium in the monitoring in the ABG or something, then we can plan. Otherwise, we don't start routinely calcium in healthy torn babies. Then regarding feed and fluids, so how we decide whether to start feeding for this baby or start IV fluids for this baby. So this is a baby, is a torn baby. The baby doesn't have any congenital malformation of the intestinal tract. So there is no anal atresia, no tracheoesophageal fistula. There is no evidence of any obstruction. Baby's perfusion status is normal. So why to start fluids for this baby? So we decided the baby should not receive any IV fluid, and we decided, okay, then let's give feeds to this baby. Once you have decided to give feeds, so what should be the volume, what should be the amount, what should be the mode, and what should be the type of feeding? These are the four things we have to decide when you decide to start on this feed. So we have decided give total enteral nutrition or full feeds to the baby. But as the baby has a respiration rate of 76 per minute, baby was on CPAP. So the mode of feeding we cannot give by Palada. So mode of feeding is by OG tube. So the volume, again, as we have already discussed in the previous lectures, if the baby is more than 1 kg, day one we used to start at 60 ml per kg, and if it is less than 1 kg, we used to start at 80 ml per kg. So here the total volume we decided give 60 ml per kg, and the choice, always it is mother's own milk or pasteurized donor human milk. So we have given here 60 ml per kg per day with mother's own milk through OG tube feeding, then 2-hourly versus 3-hourly feeding. So for a torn baby, we used to go for a 3-hourly feeding. So the frequency of feeding was 3-hourly. Next, G for glucose monitoring. So because this baby is stable, baby is not on IV fluids, so and there is a history of gestational diabetes. So we planned for RBS monitoring at 2 hours, 6 hours, 12 hours, 24 hours, 48 hours, 72 hours of life as per our unit protocol. Then, so this is the initial job what has been done by the nursing officer in our NICU. Now, this is initial stabilization. So baby was put on, temperature was maintained, airway was maintained, breathing was controlled with CPAP, circulation was normal, drugs vitamin K was given. We have decided to start on feeds 60 ml per kg, no IV fluids for the baby, and glucose monitoring at subsequent 2 hours, 6 hours, 12 hours. Then the doctor has now planned to look for what may be the possible cause of this respiratory distress for a 38-weeker baby. So because our unit doesn't go for a X-ray, we wanted to go for a long ultrasound score. So continue care. So continuing what we will continue? So we have monitored the baby for CPAP adequacy and optimized CPAP. So what I have already described, what is the adequacy of the respiratory support. So when we are putting this baby on bubble CPAP, we need to look for bubbling, what is the pressure we are given, what is the retraction of the baby, what is the saturation, and the saturation already we discussed, the target saturation should be 90 to 94% and the retraction should be minimal. So we need to monitor for the CPAP adequacy and optimize the CPAP. So another thing, so what type of interface? So we used to use the mask. We used to have a proper seal so that there is no leak from the mask side. Then what is optimal CPAP? We have already discussed. Then what other things we need to monitor? So every 1 hourly, we used to monitor for the temperature of this baby, respiration rate of the baby, heart rate of this baby, capillary refill time or perfusion of this baby, saturation of this baby. These are the things we need to have an ongoing monitoring what we expect our nursing officer to do. Another which is more important is we have started because the baby has a SS score of 5/10. So now we have given some support. Now we have to see whether this score is coming down or not. So that's why we need to monitor respiratory distress. It may be down A or Silverman underscore score every 1 hourly, because we want the score should be minimal. That is our adequate CPAP support. And we need to continue monitor for perfusion because we have started on full feeds for this baby. So we have to monitor for the feeding allowance. So what we monitor here is continuously every 2 hourly before giving the next feeding, every 3 hourly here for a term baby. We monitor the abdominal guard and we look for any signs of vomiting or particularly altered color or blood serum. So if the abdominal girth is more than 2 centimeter, then only we go for the NG tube or OG tube aspirates. Then this baby was monitored continuously, and at 6 hours, the baby's temperature was normal. The respiration rate, which was initially 76, has come down to 66 now. The respiratory distress score, which was initially 5 by 10, now it is 1 by 8. The saturation is 98% on CPAP of 6 and 35%. So initially 5, 30%. So now we have optimized to increase to 6 and the FiO2 of 30%. But here one thing you must be seeing, noting down is the respiratory distress score, what we have mentioned is 1 by 8. But I told in the earlier picture, the total score is 10. So what we have done is, so because we have put the baby on CPAP, so actually it is not ethical to remove the CPAP from the nasal mask, remove the mask and look for nasal sparing. So we need to avoid the nasal sparing part and rest for the other 4 parameters. That's why my score is maximum is 8 years. So here the SS score is now 1 by 8 with CPAP of 6 and 35%. That means my respiratory distress has gradually come down and it is settling at 6 and 35%. This may be the highest requirement. What are the other parameters? The heart rate was normal, CRT less than 3 seconds, BP normal, mean BP, you know, mean BP is the mean gestational age. So here it is 38 weeks, means mean BP 38 means the blood pressure is normal, peripheral pulses are good. So now I have seen the baby is stabilized at 6 and 35%. So we are gradually monitoring this baby, and with time we decided we have to titrate the FiO2 depending upon your targeted saturation. My targeted saturation is 90 to 94% and retraction has to be minimal. So respiratory distress score, according to that, I have to decrease the CPAP. So CPAP was decreased from 6 to 5 and FiO2 was decreased to 25%. And feeding was continued by OG2 as there is no signs of interference. So at 12 hours of life, just see what is the picture. So the baby has a persistent respiration rate of 60 per minute, but comfortable on CPAP of 5 and 25%. Long ultrasound, what has done, it was showing predominantly B lines. So B lines is nothing but because of increased long fluid. So there is more long fluid it is describing. Then sepsis screen is done because the baby has a persistent respiratory distress. So that's why sepsis screen was done to rule out sepsis. So initially we thought baby, there was no risk factor. Baby may settle with time, but the baby was not settled. That's why we thought of sending a sepsis screen, and plan was to continue CPAP. Again, at 24 hours of life, respiration rate still come down. Baby is comfortable now with CPAP of 5 and FiO2 has come down from 25 to 21%. Respiration score was again 0 by 8. Perfusion normal. Tolerating feeds, sepsis was negative. So now we thought maybe the baby is now maintaining the targeted saturation with minimal respiratory distress, with no respiratory distress, minimal CPAP requirement. So we thought, so let's plan to remove CPAP and monitor for respiratory starter worsening, if any. Because if I remove CPAP, the baby needing some support and I am removing, again, the work of breathing is going to go up. So we have removed and continued monitoring for the worsening. So what was my summary here? So my summary of this case is a 38-week AFT boy baby without any resuscitation at the birth with infant of diabetic mother. GDM is the risk factor, antenatal risk factor. Respiratory distress was onset in the delivery room, managed with respiratory support 6 by 30%. That was the maximum. But clinical signs of sepsis was absent. What may be the clinical signs? Suppose feeding intolerance, recurrent vomiting, abdominal distension, poor perfusion, tummy to temperature difference, off-colored baby, or CRT more than 3 seconds. So you can think the baby has gone into sepsis, signs of sepsis. So here there is no clinical feature of sepsis. Even the blood screening was negative and the long focus was showing excessive long fluid. So what is my diagnosis here? I told you if the onset is within first 6 hours of life, in a term maybe 3 practical causes: meconium aspiration syndrome, asphyxia, and TTNB. So here there is no meconium aspiration syndrome, and then it is not fitting into the criteria of asphyxia also because the baby cried after birth. So only diagnosis is transient tachypnea of newborn. But again, transient tachypnea of newborn is a diagnosis of exclusion. So we have ruled out sepsis here. We have ruled out RDS or meconium aspiration here, and finally we put the diagnosis of TTNB. This is the common picture what you see in day-to-day in our NICUs. Next, we go to another next case. So we'll discuss another premature baby, what we see in the NICU. So this is a baby, mother is a 28-year primey, again married since last 4 years, admitted to labor room at 27 weeks of gestation for preterm onset of labor pain. So mother had history of loose motions for last 2 days. That may be the cause why the preterm labor pain has started. Mother has received 1 dose of injection dexamethasone. Antenatal USG was done after mother was admitted. It was again correlating with gestation of 27 weeks, weight of 900 grams. A5 was normal, Doppler was normal, and there was no gross fetal congenital anomaly. And with preterm labor, so the baby was delivered by spontaneous vaginal delivery within just 4 hours of admissions. So there was no scope of giving injection magnesium sulfate, and only 1 dose of dexamethasone we could give at the time of admission because the mother was admitted with preterm labor. So baby had weak cry after birth, required resuscitation, PPB for 60 seconds. And again, this baby again developed respiratory distress in the delivery room, and the birth weight was 940 grams, girl baby, and baby was admitted to the NICU in view of extreme prematurity, that is 27 weeker, 940 grams, and onset of respiratory distress at the time of birth. Similarly, as I described in the past, the initial NICU care, we classify in terms of temperature, airway, breathing, circulation, consciousness, drugs, electrolytes, feeds or fluids, then G for glucose monitoring, T, A, B, C, D, E, F, G. So for temperature, what we have done, the baby was put in the radiant warmer and the admission temperature was 36. So again, the baby is in cold stress, and gradually the baby will, with radiant warmer, it will increase the temperature. So airway, head was in neutral position, there was a shoulder roll, the secretions were cleared. Again, one thing here I want to tell regarding radiant warmer versus incubator. So here incubator was not available, that's why you have put the baby on radiant warmer. But ideally, any baby who is delivered less than 32 weeks or less than 1500 grams, the baby ideally has to be there in the incubator. But incubator, as you know, it is more costly. So most of the units may not be having. So that's why, or here in our place, because the incubator was not available, we have put this baby on radiant warmer. So incubator along with temperature, it actually provides humidity around the baby. So for a 27 weeker, if we put this baby on incubator, ideally we can decrease the insensible water loss significantly in that baby. So airway was managed, then breathing. So what we have done, we have connected this baby to pulse oximeter and we have evaluated for the signs of respiratory distress. So respiration rate was 80, saturation was 86%, AC score was again 5/10. So the baby was started on CPAP of 5 and 30% and continually monitored. The circulation status, heart rate was 160, again that is 140 to 160 is normal, so here it is normal. CRT 4 seconds, in a preterm baby, 27 weeker, 3 to 5 seconds is normal, so here CRT is also normal. Baby is looking pink, but there is baby was periphery was cold, again that is cold stress, so that can be taken care of by the radiant warmer. So our assessment for the circulation was the perfusion is normal. So consciousness status, the baby is alert. Then what drugs we'll give? So we have decided any baby so we have to give vitamin K. So here the baby is less than 1 kg. So we decided give vitamin K 0.5 milligram IM. Then because this baby is less than 30 weeker, this baby required respiratory support. Then that's why we thought to prevent or the bronchopulmonary dysplasia, to prevent the risk of bronchopulmonary dysplasia. So we started injection capping 20 milligram per kg. So we have started and we maintained with 5 milligram per kg. So do you want to start antibiotic this baby at this point of time? So again, there is a big question mark. So here, what are the risk factors? So there are 2 risk factors one present. One is there is a spontaneous onset of prematurity. That is one point is there. And second, there is only one risk factor. So loose motion again is not a risk factor, but if there is a maternal history of maternal fever, evidence of bacterial infection, then we can thought. So if you look at the risk factor, there are 6 or 7 antenatal risk factors that can predispose for alliance sepsis, like babies, spontaneous onset of prematurity less than 2 kg, then multiple PV examinations or single unclean PV examination, then history of PRM more than 18 hours duration, history of maternal fever in the preceding 14 days with evidence of bacterial infection, perinatal asphyxia babies or Apgar score less than 4 at 1 minute. So these are some of the risk factors for starting antibiotics. If more than 3 risk factors are present, we can think of start antibiotics. But if 1 or 2 risk factors present, so better to monitor this baby, look for evidence of any infection are present, then to start antibiotics. Or else you can plan anytime to send a sepsis screen and decide. So here we have not decided to start any antibiotic because there is only 1 risk factor. Because this baby is a less than 32 weeker, so and the baby we decided to start on IV fluid. So electrolytes we decided give injection calcium gluconate 4 ml per kg. Then regarding feeds and fluids, so because this baby is less than 22 weeker, so we decided so this baby will be needing IV fluids and that too total parental nutrition. So we decided to start total parental nutrition with GIR of 6 milligram per kg per minute, aminovan of 2 milligram per kg, 2 grams per day, and lipid of 1 gram per day. That is as per our unit protocol we have started. And for babies who are less than 1 kg, we can start 80 to 100 ml per kg per day. So here the consultant was on duty. He started with 100 ml per kg per day. So regarding feeding, whether we can start feeding or not for this baby, so because it's a 27 weeker, got maybe immature, so we cannot start total enteral nutrition. But so there is no contraindication here for minimal enteral nutrition or a tropic feeding or a colostrum swallowing. So what we decided, so we'll start with minimal enteral nutrition or tropic feeding from day 1 immediately after birth. So that is 10 milligram per 10 ml per kg per day. Again, it should be mother's own milk. It should be human milk, no formula, no cow's milk, nothing. It should be mother's own milk, and the mode should be OG tube, hourly feeding. And if it is suppose mother's own milk is not available, then we can go for a colostrum swabbing over the mouth also. So always in our unit, we used to take consent before we give donor human milk to the mother, to the newborn baby. So again, glucose, we planned glucose, RBS monitoring 8 hourly because we have started on IV fluids for this baby. And the NICU doctor, as per the previous case, here also, the doctor wanted to do a long ultrasound in place of X-ray to look for what is the status of in the long ultrasound. So at 2 hours of life, so what we have seen, the baby has a persistent respiratory distress, 80 per minute. So baby initially it was started on 5 and 30. So now the CPAP pressure requirement has increased to 6 and 30%. And the long ultrasound score, what the doctor has seen, it shows plenty of B lines and the score of 12. So as per the criteria, if the long ultrasound score is more than 8, if the CPAP requirement is more than 6, or FI2 requirement is more than 30%, then you can plan for surfactant. So again, there was a background history. It's a 27 weeker. The baby has received only 1 dose of antenatal steroid. So benefit of, so we thought maybe the possibility of hyaline membrane disease or RDS is there. So we have planned to give surfactant to this baby and to continue CPAP. So coming to surfactant, so there are 2 techniques how we can give surfactant. That is the insure technique or LISA technique. So insure is intubate the baby, give surfactant, then again extubate the baby to the CPAP. And LISA technique is, here in the LISA, we don't intubate the baby. What do you give? We just see the trachea, put a feeding tube, put a tube into the trachea, feeding tube into the trachea, and give the surfactant. So that is less invasive surfactant administration while the baby is on continuous CPAP. So in insure, actually, you are removing the baby from support. So you are intubating, giving surfactant, doing some bag and tube ventilation to help the surfactant to disperse, and then extubating, putting on CPAP. But in LISA, we are not removing the nasal mass or nasal prong. So baby is on continuously on CPAP. Just we are putting a catheter into the trachea and inserting the surfactant through the trachea. So we decided to continue CPAP following surfactant therapy, and we go for continuously. We wanted to monitor the Silverman-Anderson score every 1 hour. So we were monitoring. So at 6 hours of life, we found the respiration rate is 70. Babies are comfortable on CPAP of 6 and 30%. SS score has come down now to 2/8. Initially it was 5/10. Again it is 2/8. So why the total score is 8 here? Because we don't want to remove nasal mass from the baby or remove CPAP nasal mass to score the nasal pharynx. So it was score was 2/8, but the perfusion was normal. But sepsis screen was planned in view of risk factors. Sepsis screen usually used to plan after 6 to 8 hours. Immediately after birth, if you are going to, then probably the sepsis markers may not come positive. So again, we have gone for a repeat ultrasound, long ultrasound, because we have done at 2 hours. We wanted to see whether there is a long ultrasound improvement was done there or not. But we have seen the score is now again 10. So looking at the SS score, Silverman underscore, so 2 by 8. So 2 by 8 is also significant for a baby who is delivered at 940 gram 27. So we continued our CPAP and ongoing monitoring of the respiratory status worsening. So at 12 hours of life, we found this baby has persistent respiration rate of 66 per minute, on CPAP of 6 and 30%, and SS score again, it is 2 by 8. And what we got the sepsis screen report now, the sepsis screen is positive. So depending upon the persistent respiratory distress, positive sepsis screen, we started on IV antibiotic as per our unit protocol after sending back tech and CSF. And the plan was to continue CPAP, continue IV antibiotic, continue injection caffeine, and ongoing monitoring. So again, we monitored this baby at 24 hours of life. So respiration rate came down to 62. Baby is now comfortable with CPAP of 6, and FiO2 was varying between 25 to 30% to maintain the target saturation of 90 to 94. And the respiratory score has come down now to 2 by 8. And perfusion was normal. So we plan to continue the TPN, antibiotics, and caffeine and monitor the score. So again, what 48 hours. So these are the usual scenarios what you see and how you monitor. So I just wanted to have you overview a practical case, what actually and how we are managing a respiratory distress. So at 48 hours of life, SS score was 1 by 8. Baby comfortable on CPAP of 6 and 25%. So because the baby on day 1 started on 10 ml per kg, on day 2 we thought we'll increase the feeds because there is no shock. So we increase feeds by 20 ml per kg per day. So that is feeding of 30 ml per kg per day we have given through OG tube, mother's own milk or the donor human milk, and fluid rest amount, that is 90 ml per kg. So was given TPN with injection calcium gluconate. So that the total fluid plus feed intake is 120 ml per kg per day on day 2. So plan was to continue CPAP, monitor for any worsening with the target saturation of 90 to 94%. So baby was ongoing monitored at 72 hours of life. Again, the respiration rate was 62. Respiration rate distress score was persistently 1 by 8. Baby was continued on CPAP, and FiO2 was in between 21 to 25% to maintain saturation of 90 to 94. The perfusion was normal. Baby was tolerating feeds. So plan was to increase the feed from 30 to 50 ml per kg and decreasing the TPN amount. So the plan was continued 6 to 5 because the baby was stabilized in last 48 hours. Almost we have seen the baby is maintaining 6 to 21, 6 pressures and 25 to 21%. And baby is quite comfortable, score of 1 by 8. So we wanted to titrate the CPAP. So continue the CPAP of 6 by 5. From 6 pressure we have decreased to 5. FiO2 continued at 21%, and ongoing continuously we wanted to monitor the respiratory status worsening, if any, with target saturation of 90 to 94. So this baby, again, 940 gram, 930 gram, 22nd week or baby, they will be requiring prolonged CPAP support. So with 1 by 8, we just wanted to continue this baby till this baby gains weight a bit, the baby is comfortable. We are not allowing any work of breathing for this baby so that the baby can start gaining weight and baby doesn't go into repeat respiratory distress or increased work of breathing. So if I summarize the case too, so this is 27 week or 930 gram, appropriate for dead girl baby who required positive pressure ventilation for 60 seconds at the time of birth. And there was, what are the risk factors here? Preterm labor, suspected maternal infection, the loose motions, but again, unexplained preterm labor may be a sign of occult courier amenorrhea. So we need to be careful for that. Also, there is an incomplete dose only of antenatal steroid. Here only 1 dose of antenatal steroids was given. So respiratory distress was started at was onset was in the delivery room. So baby was managed. How it was managed? So with CPAP maximum of 6, FiO2 35%, given surfactant within 2 hours of life in view of high long ultrasound score, CPAP requirement more than 6, and FiO2 requirement of 35%. With that criteria, and injection caffeine was started to prevent chronic lung disease. As you know, this premature baby requiring resuscitation, suspected infection, sepsis. So these babies are at high risk of bronchopulmonary dysplasia. The risk may be almost 20 to 40% for a baby who is delivered at 28 weeks of less than 28 weeks of gestation. So we have continued that caffeine. Sepsis screen was positive. That's why we have decided to start antibiotics, and we wanted to continue here for maximum 5 days looking at the clinical picture. But if the sepsis screen is positive, blood culture is negative, CSF is negative, and if you can strongly monitor this baby, so you can still stop the antibiotics once the blood culture is negative. Again, the long focus was persistently showing a high score of more than 8. So what may be the possible diagnosis here? So there may be the diagnosis of respiratory distress syndrome or hyaline membrane disease. Also, alliance sepsis or congenital pneumonia may be also the cause here, because we could, with background history of preterm, unexplained preterm labor, suspected maternal infection, so we cannot 100% rule out it is a congenital pneumonia. So this may be the two differential diagnosis for this baby when for managing the respiratory distress. So coming to the summary, so whenever we are receiving a baby, so just don't get satisfied with the respiration rate only or retraction only. So always have a quantification of the amount of respiratory distress the baby has or the respiratory distress score. For a torn baby, prefer Down's score. For a preterm baby, you can prefer Silverman-Anderson score. But at least do a respiratory distress scoring periodically. That will help me to identify whether the baby is improving with your support or the baby needs escalation of support or intubation. Then second point, what is most important, use oxygen judiciously with a less than 2 liter low flow oxygen, more than 2 liter high flow oxygen. But always whenever you are using more than 2 liter of oxygen, always it should be heated and humidified. Third point, the target oxygen saturation should be for a term or preterm, it should be 90 to 94%. So as a nursing officer, please set your pulse oximeter alarm limits of the target saturation from 88 to 95 or 96 maximum, so that maximum time the baby is in between the 90 to 94 range. Fourth point, we have to decide the lung is adequately recruited. So how you know this lung is adequately recruited? Looking clinically at minimal retractions, and if you go for X-ray, there is no overinflation of the lung. So it should be within 6 anterior ribs. Then always avoid ventilator-induced lung injury. So by avoiding invasive mechanical ventilation, so always try with non-invasive support. Only when it fails, then you go for an invasive support, or only when you are sure this baby has already gone into respiratory failure, baby doesn't have a spontaneous respiratory dive, then only you take full control of respiration of the baby by invasive mechanical ventilation. Last, not the least, is the supportive care. Putting the baby in a nesting, nutrition, developmental supportive care, minimal handling, allowing the baby to sleep properly, that is equally important when we are managing this baby with a respiratory distress. Because at the end of the day, our target is not only diagnosing the cause of respiratory distress and managing, also to maintain this baby in a environment or in a developmentally supportive environment as if the mother would have been inside the uterus, so that my target of intact survival is fulfilled. So thank you very much for all of you for your patient hearing. So any questions or any doubts, you can just WhatsApp in your groups. We can discuss in that. So thank you so much.